Hi, my name is Colleen Bridges, and I want to thank you for joining me today in this workshop focused on Parkinson's disease. I am an NSCA certified personal trainer with almost 20 years experience working with over 200 plus people living with Parkinson's disease. So I have a great deal of firsthand knowledge that I would love to share with you. Our time will move quickly, and unfortunately, I won't be able to go into great detail about Parkinson's disease since it's so complex, but this will be a great starting point. At the end of my presentation, there will be some time for comments and questions, but in case I don't get to your question, I have my contact information on the last slide, so please feel free to email me with any further questions. Okay, let's begin. Winter brings beautiful snowfall to so many of us each year. It can be so peaceful to stand at the window and watch the snow fall and blanket the earth. Fun fact, did you know that if you take a close-up picture of a snowflake just as it lands on your coat or your glove, and then you zoom in on that snowflake, you can see all the intricate parts of the snowflake? It's one of my favorite things to do. And year after year, I'm constantly amazed at how each and every snowflake is completely unique. There are no two snowflakes alike. Guess what? Parkinson's disease is exactly the same. Just because you know one person with Parkinson's disease means, well, you know one person with Parkinson's disease. I can have 20 or more people in a class, and the only similarity they have is that they all have Parkinson's disease. Their symptoms, their reaction to medication, the rate of progression is different for every single one of them. Thus, the nickname, the snowflake disease. There are approximately 1 million people living with Parkinson's disease in the United States and 10 million worldwide. Every 9 minutes, someone is diagnosed with Parkinson's disease. That means at the end of the day, 144 people will hear these 4 words: you have Parkinson's disease. Most newly diagnosed Parkinson's patients don't even know what Parkinson's is other than a tremor and that Michael J. Fox lives with it. And more importantly, many fitness professionals do not have a basic knowledge or understanding of what Parkinson's disease is and how it changes everything when it comes to exercise program design. So let's start with a brief explanation of Parkinson's disease. Over 200 years ago, a man by the name of Dr. James Parkinson took notice of abnormal movements in some of his patients and people on the streets of London. He later referred to this as the shaking palsy. Since then, the medical and scientific community has made great advances in treatment options while continuing to work towards a cure. Parkinson's disease is a progressive degenerative neurological disease that affects dopamine-producing neurons in the substantia nigra, which is Latin for black substance. The substantia nigra contains the most dopamine neurons and is a part of the basal ganglia, which is responsible for control of movement, along with many other tasks. The lack of dopamine neurons in the substantia nigra causes Parkinson's disease to manifest itself in the form of motor and non-motor symptoms. These symptoms do not occur suddenly, but evolve over a period of time, a long period of time. Most people are not even aware they're presenting symptoms of Parkinson's disease until a loved one brings their attention to it, such as a tremor, a lack of an arm swing, and maybe a series of falls, for example. Now, diagnosing Parkinson's disease can be very tricky. Currently, doctors must rely on a physical examination, health history, and medication trials because CAT scans and MRIs and PET scans do not give a specific enough information for a doctor to make a definitive diagnosis. And the symptoms? Well, let's just say that Parkinson's disease is not for the faint of heart. Imagine with me for a moment a giant iceberg. Above the water You see the motor symptoms such as tremor, rigidity, bradykinesia, which is slowness of movement, dysphagia, which is a swallowing problem, hypophonia or softening of the voice, dystonia, which is cramping of the limbs, facial masking, which is a lack of facial expression and freezing, to name a few. But below the water, that's a whole new set of non-motor problems that you're probably not aware of, such as cognitive changes. For example, problems with attention, planning, language, memory, or even dementia. Constipation, excessive sweating, often when wearing off medications. Fatigue, increase in dandruff, hallucinations and delusions, orthostatic hypotension, loss of smell and taste, mood disorders such as depression, anxiety, apathy, and irritability, pain, sexual problems, sleep disorders such as insomnia, excessive daytime sleepiness, REM sleep behavior disorders, vivid dreams, restless leg syndromes, urinary urgency, frequency, and incontinence, vision problems, particularly when trying to read something up close, weight loss, drooling, and the list goes on. Utilizing a case study about Bob, a patient living with Parkinson's disease, you will get a basic understanding of how Parkinson's disease affects people. After this workshop, I invite you to expand your knowledge and skill set so you can successfully work with people living with Parkinson's disease by taking my MedFit course, Parkinson's Disease Exercise Specialist Certification. Now, let's get into the case study. Bob is a 70-year-old white male. Bob exercises 3 to 4 times a week, playing tennis and private sessions with a personal trainer. Bob is active in his community. He volunteers in his church's garden club and works once a month at the local food bank. Bob has no history of stroke or heart disease. However, in his 20s, Bob was in a car accident which reportedly caused lumbar and cervical sprains. He has a prior history of depression. Bob is happily married to Luann and they have grown children and 4 grandchildren. Bob is going to his doctor with the following symptoms: tremor in the pointer finger of his left hand, muscle stiffness, slowness in mobility, which is bradykinesia, and occasional aches and pains that Bob assumes are normal with aging. Also, while Bob was playing tennis recently, he stumbled but quickly recovered his balance. In 2012, Bob noticed a persistent tremor in his left pointer finger, but not any other extremities, and he assumed it was the result of overdoing it on the tennis court and working out with his personal trainer. The tremor continued, and over time, Bob also developed muscle stiffness and slowness in mobility, which concerned Bob enough to go see his doctor. The doctor reviewed Bob's health history, performed several movement tests during his office visit, and did an X-ray on his back. Upon completion of the exam, Bob's doctor had sufficient information and referred Bob to a local neurologist to confirm a suspected Parkinson's disease diagnosis. Indeed, the neurologist made a Parkinson's disease diagnosis and put Bob on Parkinson's medication. Various combinations of medications were tried before finding that the medication carbidopa-levodopa provided the most relief for Bob. Bob maintained his medication regimen for 5 years without any problems. During the first 5 years of living with Parkinson's disease, Bob moved to a small town in Mississippi, which did not have a neurologist. A local internist agreed to monitor Bob for signs of increasing symptoms and/or problems with his medication. In 2017, Bob noticed increasing weakness and tingling in his left leg and more pain when standing. Specifically, he noted he could no longer raise himself on the tiptoes of his left foot and soon after his right foot. A trial of increased dose of carbidopa-levodopa, his Parkinson's medication, provided inconsistent relief of symptoms. Tennis irritated the issue. Assuming that it was Parkinson's related, Bob's personal trainer added bridges and clamshells to his exercise program to increase Bob's lower body strength and asked him to take longer walks. But before long, the pain became debilitating and Bob became sedentary. The weakness and tingling in his feet worsened to the point he could no longer continue his volunteer work. Depression set in, and Bob's physician added Wellbutrin to his medical regimen. Bob's tremors, rigidity, and bradykinesia continued. Additional symptoms appeared, such as constipation, poor sleep habits, severe dry eyes, heartburn, leg cramps, and muscle weakness. The increase in symptoms took a psychological toll on Bob to the point where his internist suggested that Bob consider surgery to stimulate the brain. Since the doctor did not feel Bob was in an emergency situation, he made an appointment for Bob to see a neurologist in 6 weeks. A month before his neuro consultation, Bob spoke about his Parkinson's disease journey at a community event for Parkinson's disease. A physical therapist was in the audience, and after the lecture, she approached Bob and said, "I have never seen a Parkinson's patient who has muscle weakness, particularly to the extent you are experiencing." That was a turning point in Bob's life. Bob went to see the physical therapist for an evaluation and was asked to stand on his tiptoes and on his heels. Upon observing these exercises, the physical therapist noticed that Bob showed 3 out of 5 strength of plantar flexion of both feet, while dorsiflexion was 5 out of 5 strength, which revealed compressive neuropathy. An MRI sealed the diagnosis. Let's break this case study down and take a quiz so we can see what we know and what we don't know. Bob is 70 years old. He's active. He exercises. He has no history of stroke or heart disease. He's happily married, but he is going to the doctor for the tremor and the muscle stiffness and the slowness of mobility. He does get diagnosed with Parkinson's disease, and he's put on carbidopa-levodopa. During the initial visit with the doctor, what is the doctor observing the patient for? A, slowness of movement, tremor and stiffness. B, lack of balance. C, tremor and stooped posture. D, A and B. A physician is trained to observe the patient from the moment they enter the room. In order to properly diagnose Parkinson's disease, the physician will be looking for 3 of 4 symptoms: tremor, bradykinesia, which is an umbrella for many issues, stiffness, and/or gait and balance problems. Next question. What type of tremor do people living with Parkinson's disease have? A, tremor while performing an activity of daily living. B, resting tremor. C, age-related tremor. D, malignancy tremor. The answer is B. Some people living with Parkinson's disease have a resting tremor, but not all. When they are active, the tremor, especially in the beginning, is only noticeable when the limb or the chin or the mouth is resting. Tip: symptoms are usually unilateral in the first stage. What are some examples of bradykinesia? A, decreased blinking. B, monotone speech. C, shorter gait. D, all of the above. As I mentioned earlier, bradykinesia is an umbrella for many movements that people living with Parkinson's disease deal with every single day. The answer is D. Additional examples may include rising from a chair, getting out of the car, buttoning a shirt, even drooling. This causes an enormous amount of frustration for them and their care partners. It takes patience to get from point A to point B. With that in mind, if someone struggles with severe bradykinesia, do your best to bring the exercises to them rather than the other way around. It will save time, it'll allow for a much more productive session, and keep them from becoming frustrated. Let's move on to another question. What tests are most often performed during the initial office visit to confirm a diagnosis of Parkinson's disease? A, sit-stand test, time up and go, also called tug test, a writing test. B, balance and walking assessment. C, Exam facial expression and blood pressure while sitting and standing. D, all of the above. D is the correct answer. While brain imaging is helpful, it does not provide adequate information for the physician to make a definitive diagnosis. A physician will first review the patient's health history, then perform some, if not all, of the tests mentioned above. Next question. What medication do physicians most often prescribe to newly diagnosed people living with Parkinson's disease? A, venlafaxine, B, ropinirole, C, lisinopril, D, carbidopa-levodopa. D. Physicians prescribe carbidopa-levodopa because once it enters the body and crosses the blood-brain barrier, it changes into dopamine, and that's what they need more of. And so they can replenish their levels and move more freely. Now, when levodopa was first introduced to the Parkinson's community, patients experienced side effects that were often debilitating, such as vomiting, nausea, headache, fever, sore throat, deep fatigue, difficulty breathing, confusion, chest pain, and much more. Thanks to persistent researchers, carbidopa was added to the medication, which provides two benefits. One, carbidopa is added to the levodopa to prevent the breakdown of levodopa in the blood. That way, more of it gets to the brain when it crosses that blood-brain barrier. Number two, the addition of carbidopa allows lower doses of levodopa to be used, which reduces those awful side effects from levodopa, such as nausea and vomiting, and the other ones that I mentioned. Let's move on to another question. If Bob was able to function with little difficulty for 5 years, it means everyone with Parkinson's disease progresses at the same rate. True or false? False. Remember, no two people living with Parkinson's disease have the same experience. I have some clients who've had Parkinson's disease for over 20 years. Yes, 20 years. Naturally, the disease has progressed, but for the most part, they are active, they drive their cars, they work part-time, while some have only been diagnosed for less than 5 years and the disease has progressed rapidly. To help patients and their care partners better understand where they are in their Parkinson's journey, the doctor may refer to a scale to help them understand the progression of the disease. Parkinson's stages correspond both to the severity of the movement symptoms and how much the disease affects a person's daily activities. The most common rating scales used are the Hone and Yar stages. Following a simple rating scale, first introduced in 1967. Clinicians use it to describe how motor symptoms progress in Parkinson's disease. This scale also allows physicians and clinicians to rate symptoms on a scale of 1 to 5. So on this scale, a 1 and a 2 represent an early stage, late 2 and 3 are mid-stage, while 4 and 5 are advanced stages of Parkinson's disease. There's another scale called the Unified Parkinson's Disease Rating Scale, or the UPDRS. It is a more comprehensive tool used to account for non-motor symptoms, including mental function, mood, and social interaction. It also gives accounts for cognitive difficulties, ability to carry out daily activities, and treatment complications. I personally use the Hone and Yar for my classes and clients. Now let's look at the second part of this case study. During this time, Bob has moved to Mississippi. He does not have a neurologist, and he's beginning to notice increasing weakness and tingling in his left leg, and it hurts to the point where he cannot stand on his tippy toes and he can't walk for very long, and so he becomes depressed, which adds more medication to his already daily medication list. The tingling in his legs and weakness that Bob is experiencing is likely a symptom of Parkinson's disease. True or false? False. However, pain is associated with Parkinson's disease. Most often it is due to dystonia, which is a constant muscle spasm. Never lets go. We discussed dystonia in more detail in my curriculum. Next question. Which one of the additional symptoms listed is not considered a symptom of Parkinson's disease? A, heartburn, B, muscle weakness, C, dry eyes, D, A, and C. The answer is B. While people living with Parkinson's disease express feeling overall weakness, Parkinson's disease is not like ALS, in which the upper and lower motor neurons stop sending messages to the muscles and they gradually weaken. Typically, if someone has muscle weakness, it's because they have not been exercising. Next question. How should the fitness professional address the non-Parkinson's disease symptom? A, include more cardio exercises in their fitness program. B, refer him to his primary care physician. C, tell Bob that you believe his symptoms are common and continue his exercises, but keep an eye on the situation. Or D, remind Bob that Parkinson's disease manifests itself in unusual ways and that you're going to work together as a team to get through this. Safety first. Answer B. I have a rule that if somebody has a pain or an unexpected problem that lasts for 2 weeks, then it is time to call their PCP. We can't take any chances. I had a client who kept blaming his shortness of breath on Parkinson's disease, and I insisted that he call his PCP. Good thing, because his PCP referred him to a cardiologist, and a week later he had a triple bypass. Keep your eyes and your ears open. It's not always Parkinson's disease. What kind of surgery is Bob likely considering? Deep brain stimulation, also called DBS. B, duopa pump. C, pallidotomy. D, a pacemaker. A, deep brain stimulation, or DBS. The DBS surgery was first approved in 1997 to treat Parkinson's disease tremor. Then in 2004 for the treatment of advanced Parkinson's symptoms. Then in 2016, the DBS surgery was approved for earlier stages of Parkinson's disease. For people who have had Parkinson's disease for at least 4 years and have motor symptoms not adequately addressed with their medication. In the DBS surgery, electrodes are inserted into a targeted area of the brain using MRI and recordings of brain cell activity. Yes, your brain actually does talk, and you can listen to it. A second procedure is performed to implant an IPG, or an impulse generator battery, kind of like a pacemaker. The IPG is placed under the collarbone or in the abdomen. The IPG provides an electrical impulse to the part of the brain involved in motor function. Those who undergo DBS surgery are given a controller to turn the device on or off. In my course, I will interview a client who recently had DBS surgery. I think it's so important for you to know how to help them navigate this decision, because DBS surgery is not for everybody. And also to understand the process that they will go through to implant the mechanism. It's not simple. And then they need to understand what life will be like after surgery. It's definitely not a walk in the park, that's for sure. Now let's look at the next section. A month before he goes to the neuro consultation to talk about the possible DBS, Bob speaks at a community event about his Parkinson's, and he mentions that thinking the tingling in his legs and the pain was associated with Parkinson's. He shares that with the audience, and there's a physical therapist there, and she does several tests. What is wrong with Bob? A, osteoarthritis. B, spinal stenosis. C, muscle strain. D, sciatica. The answer is B, spinal stenosis. Spinal stenosis is an abnormal narrowing of the spinal canal. It just gets tighter and tighter and tighter. That results in pressure on the spinal cord or nerve roots. Symptoms may include pain, numbness, or weakness in the arms or legs. Symptoms are typically gradual in onset and improve with bending forward, so flexion. Here's a tip to remember. If someone is living with stenosis and cannot rise from a squatting position without pain, they have compression at L4. If someone is unable to walk on his or her heels, they have compression at L5. If someone is unable to stand on his or her toes, like Bob, they have compression at S1. Next question. What could the internist and the fitness professional have done differently? A. Recognize that not all of his issues fall under the umbrella of Parkinson's disease. B. Suggest that he move into an assisted living home. C. Give him the contact information for a reputable chiropractor. And D. Recommend that he go to a massage therapist. I think you know the answer to this one. It's A. Be willing to think outside the box. Parkinson's disease is so many things, but it's not everything. It's okay to say, I don't know, but I can ask someone who does, because it's true. We don't know everything and never will. So having an advisory team will help you when you are stumped by a difficult situation. And believe me, I constantly contact my advisory team. Let's move on to another question. As a fitness professional, what can you do in this type of situation to develop an exercise program that will help Bob enter back into an active lifestyle while also keeping in mind his physical limitations? A. Write a plan with seated exercises to allow for recovery. B. Consult a physical therapist on the do's and don'ts of spinal stenosis. C. Search online for exercise routines. D. A and B. D. Keep a chair close by so they can either lean over the chair to relieve their back and or sit down. If a client is able to continuing exercising, I have them do seated exercises using the tubes, the bands, weights, and we don't take too long of a break. I want to keep them moving. Also, I found early on that if I reached out to physical therapists and expressed an interest in learning how to better serve my clients, physical therapists were happy to help me. I had no idea that one day it would become a great referral system as well. Now, online, there are so many things out there. When you type in spinal stenosis, you're going to pull up a million different things that you can do and not do. If you do search online, please make sure that you are searching somebody that you know to be a reputable physical therapist or doctor or personal trainer. Don't just pick any Tom, Dick, and Harry and then follow through with what their advice is. Be very selective in who you get your information from. Next question. Why is Parkinson's disease nicknamed the snowflake disease? A. Symptoms are usually worse in the winter. B. People are commonly cold when they have Parkinson's disease. C. A and B. D. No two Parkinson's patients are ever the same. I think you know the answer to this one. It's D. You will never meet two Parkinson's patients with the same exact Parkinson's journey, which is why I want you to meet as many as possible of my clients and my amazing fighters here at Steady Bkxing. To help us learn more, I'd like to introduce you to the real Bob. Yes, Bob is an actual person. Dr. Bob Daggett is a retired medical professor, rheumatologist, and pediatrician. Let me just tell you, he's a genius. And he's also one of my amazing Steady Bkxing fighters. So Bob, thank you so much, first of all, for letting us do a case study on you and for being here today and helping us learn more, because that's what we want to do to be our very best. So I'm going to ask him a question. How has Parkinson's or Parkinsonism changed your life?
Well, my activities of daily living have changed considerably because of the Parkinson's disease. When I try and do things, I find that my reaction time is very slow. Normally that would make relatively little difference. However, when you're driving, it makes a lot of difference. So you have to be careful about what you do, how you do it, and what you're doing.
And talking about Parkinson's disease in this lecture that we're doing right here, but also preparing the participant for taking my course, there's a topic I didn't have time to get into, and it's about Parkinsonism. Can you tell us the difference between Parkinson's disease and Parkinsonism?
Parkinsonism is a collection of diseases with similar characteristics to Parkinson's disease. While Parkinson's disease itself called Parkinson's the disease is a separate specific disorder. When you look at Parkinsonism, it's a group of diseases that have similar symptoms. The tremor, the slow mobility, where Parkinsonism is a specific disease process.
Okay. What other information do you think that a fitness professional who is maybe stepping into working with Parkinson's disease clients for the first time needs to know?
Well, you get into most problems when you try and think that you know something and have not really understood the principles behind it. You need to know what you know, but you also need to know what you don't know.
When people are diagnosed with Parkinson's disease, or maybe somebody who doesn't know anything about Parkinson's disease, but they hear the word disease, they automatically think that they're going to die an early death. And that's very morbid. It's very kind of gloomy to even talk about. But when it comes to Parkinson's disease and just natural age, how does Parkinson's and naturally aging compare in death?
Well, there have been studies about looking at the life expectancy of patients with Parkinson's disease. When you look and compare them to the normal age-matched population, it's approximately equal. So there's no acceleration of death because of the disease of Parkinson's.
Very good. Thank you so much for being a part of our project.
Okay.
He's fantastic. Very good. While there is currently no cure for Parkinson's disease, there is hope. People living with Parkinson's disease have many medication and several surgical options to help with the symptoms of Parkinson's disease. And there's also another amazing type of treatment. And if this treatment is taken regularly and in the correct amount, it can provide incredible relief of symptoms. Yep, you guessed it, exercise. We will discuss in my course the connection between exercise and Parkinson's disease, particularly how to write an exercise routine for people living with Parkinson's disease. I can tell you from years of experience that I have seen lives transformed through exercise and the community they build with others on the same journey. So what does this mean for you, and how do you as a fitness professional prepare yourself to work with people living with Parkinson's disease and give them the absolute best training possible, because they deserve it? 1, create an advisory board. Surround yourself with a stellar group of mentors. I have an exercise physiologist, a physical and occupational therapist, a personal trainer, and several movement disorder physicians from Vanderbilt University, as well as Dr. Bob, who you met earlier. I rely on them to help me provide the highest quality of training possible to my clients and my Steady Bkxing fighters. Number 2, push yourself to better your best and take the MedFit Parkinson's disease exercise specialist certification course, because I assure you there is always something new to learn, and challenging yourself will benefit you and your clientele. And you can start with me right now by discovering what you know and what you don't know. To conclude, let's circle back to the idea that Parkinson's disease is the snowflake disease. As I originally said, no two people have the same symptoms, progression rate, or reaction to medication. The only 2 similarities people living with Parkinson's disease have with each other is 1, they each have Parkinson's disease. 2, they take medication, and they're a wonderful group of people that will touch your lives. Just like the intricate pattern of a snowflake, so are the intricacies of Parkinson's disease. Hopefully today's workshop whets your appetite to take a deeper look into these intricacies of Parkinson's, so you as a fitness professional can successfully enhance the lives of people with Parkinson's disease. Here are some specific details about my course, Parkinson's Disease Exercise Specialist Certification. 1, you're going to learn the history and epidemiology of Parkinson's disease and its effect on the body. 2, you're going to learn all about treatment options and their side effects and complementary therapies such as Steady Bkxing, dance, yoga, so forth. 3, you're going to learn the connection between exercise and Parkinson's disease. We're going to pull in research and talk about what's going on in the body when they're exercising. 4, I'm going to teach you how to teach someone living with Parkinson's how to box. It's totally different than regular boxing. This is not your regular boxing class. So I'm going to teach you how to teach people living with Parkinson's how to box. 5, I'm going to teach you the what, why, and how to writing an effective exercise program for people living with Parkinson's disease. 6, we're going to take that information and we're going to have part 2, which is effective program design, progressive and regressive exercises for people living with Parkinson's disease. I'm going to teach this course through a combination of narrated slides, presentations, video demonstrations, handouts. I'm also going to include interviews that I do with my fighters, my clients. I call them fighters because they are in for the fight. I'm going to give you at least 4 full routines with over 100 exercises, exercise charts, a chart on how to progress and regress exercises. I'm going to give you information on drugs, like multiple drugs and their side effects and what you need to know about it, because believe me, the drugs make a big difference in how they feel and how they're able to function. There is so much information packed into this course. It's basically everything I wish I had known 17, 18 years ago when I started working with people living with Parkinson's disease. I've had to learn it over time and through what I call the School of Hard Knocks. I finally have a PhD in the School of Hard Knocks. But it's information that I want you to know now. I don't want you to have to wait and have something occur in a session and you go, oh, I wish I had known that. So everything I can possibly think of and the kitchen sink are in this course. I leave you with this. Fitness professionals, we owe it to this absolutely precious population to be educated, experienced, and enthusiastic about walking alongside them on this Parkinson's journey. Thank you so much for joining me today, and I look for any questions that you might have, and I close with this. Fighting back against Parkinson's disease does not take a day off. Together, will you join me in helping transform their lives from hopeless to hopeful?